Okay, good afternoon, everyone. Thanks for coming. I'm really grateful for my role today because if you stayed so long after the second day of the conference, coming here to listen what we have to say about the diagnostics and treatment of groin pain, it means you're really interested in this, and this makes our job a little bit easier. I know you're tired, so we won't make it too difficult. So this is the Groin Injuries Workshop. My name is Zarko Vuckovic. I'm a general surgeon working in Aspetar in our groin pain center. And as you can see on this picture, lower right, I have some experience in handball, winning gold medal with the youth team here in Doha 10 years ago. Our team for today is Adam Weir, who is a sports medicine physician and a deputy head of Groin Pain Center, Aspetar. Gilles Reboul, who is also a general surgeon, coming from Clinique du Sport Mérignac, Bordeaux, and also working in Aspetar. And Roald Otten, who is our physiotherapist here in Aspetar. This is the agenda for today. We'll go through the introduction and some groin cases that you have in your handouts. Then Dr. Weir will tell you something about anatomy and terminology. Then we'll go through the groin examination practical session, and you can also find a nice paper about the examination in your handouts. Then we'll have some practical session about conservative treatment by Roald. Then I'll tell you something about the inguinal surgery, and at the end, Dr. Reboul will tell us something about adductor surgery. So let's start with our clinical cases that you have in your handouts, just to warm up. So case one, this is the history. We have a male amateur handball player. All players here are professional, but in some leagues like Australia, they're probably amateur. Trains on a daily basis, no previous history, has gradual onset of first episode of left-sided groin pain over the past 8 weeks. Pain is around the proximal adductors and insertion on the pubic bone, worse on sprinting, jumping, sporting activities, sore after cooling down with pain the morning after. He was initially able to do sports, but last 2 weeks he has pain after warming up and now unable to perform. Past medical history, no previous injuries, just lateral ankle ligament injury with good recovery, medically fit, no allergies. So just a little summary. This is the pinpoint. Gradual onset, left-sided groin pain 8 weeks, proximal adductors and the pubic bone, worse on sporting activities, pain after cooling down and the following day. And since 2 weeks, the pain was getting worse and now unable to perform. In examination, we have a healthy athlete, normal spine, mild varus or normal pelvis. You can see that hips range of motion is pain-free and normal, full. No swelling or bruising or in the groin region. On palpation, he has palpation on the proximal adductor longus tendon and the attachment of the pubic bone. No pain on the iliopsoas, rectus abdominis, inguinal canal, inguinal ligament, conjoint tendon, other structures in the groin region. Resistance testing on hip adduction at 0, 45, and 90 degrees. He has pain at the adductor insertion with moderate strength, so there's decrease in power. Hip flexion at 0 and 90 degrees, no pain, good strength. Hip abduction, no pain, good strength. Abdominal sit-ups, straight and oblique, no pain, good strength. On stretch tests, symmetrical length of the adductors, but mild pain on stretching of the left adductors in the proximal part. And symmetrical length of testing of hip flexors and no pain. Again, this is what we are focusing on. Proximal adductor longus tendon pain on palpation and the pubic bone. Hip adduction tests are painful with some weakness and some mild pain on stretching of the left adductors. We did some imaging for this guy. We do the x-ray just to exclude the majority of things. And you can see there are just some changes on the right hip, but it's not clinically relevant in this case. And on the MRI, since he has pain and the X-ray was normal. We did an MRI, and there is some bone marrow edema on the left pubic bone due to chronic adductor dysfunction. There are some cystic changes at the proximal origin of right adductor longus. He has pain on the left, and more or less everything else is normal. So I would ask you, what would be your diagnosis in a case like this? We tried to classify groin pain in these 5 categories, and you will hear a little bit more later on during the day when we talk about terminology. But I'm just showing this so you can think about it, and then later on we'll try to give you some answers. Then we have the second case, a 31-year-old professional handball player, same training every day. He had several episodes of groin pain in adductors and in the inguinal region, with normally treated with some rest, modified training, oral inflammatories as usual. And in the past, the pain would settle in 2 to 3 weeks. Now he has a gradual onset of left-sided groin pain last 6 weeks. Pain is located around the inguinal region on the left side, worse on sprinting and changing directions. He's initially able to train and play without performance being affected, but since 4 weeks, again, pain immediately after warming up, cannot sprint fully, change direction. He had right-sided partial medial meniscectomy in the past, and with good recovery, had some contusions, hamstring strain on the left side 3 years ago with good recovery, medically fit. So this is what we are focusing on. On examination, healthy athletic male, lumbar spine normal, full pain-free range of motion. Hips normal, full range of motion, pain-free. No swelling or bruising in the groin region. He has some pain on palpation of the left external inguinal ring, conjoint tendon, and inguinal ligament. No palpable inguinal hernia. No pain on the proximal adductor tendon or the pubic bone. No pain on the ellipsoas, rectus abdominis, or other structures. Resistance testing, hip adduction, no pain, good strength. Hip flexion, no pain, good strength. Hip abduction, no pain, good strength. Abdominal sit-ups, straight. He has some pain in the left inguinal region, but with good strength. And in oblique sit-ups, he has some pain in the left inguinal region with good strength. On stretch test, symmetrical length of adductors, no pain. Symmetrical length of hip flexors, and no pain. This is the only thing we could find in physical examination. In this case, we again did the X-ray of pelvis and both hips. Basically, there's just moderate sclerosis of the pubic symphysis on the X-ray, normal findings, more or less. You would find that in every athlete in every sport. And on the ultrasound, because of the inguinal region, we do the ultrasound to assess all the adductor tendons and also the posterior wall of the inguinal canal. We can see that there is moderate bilateral bulging of the posterior wall, predominantly on the left side, on the painful side. Again, we ask ourselves this question, what is the diagnosis? And we have 5 possible answers. That's the way we see it. Okay, now for real, if you have any questions, we're happy to answer. Yes, please.
You describe the adductor longus as anterior part is a tendon and the posterior part is the muscle. This is a good sign for the good improvement for healing or no?
It was Adam's presentation, but I'll try to explain. When it's the muscular part and less tendinous, it's a good vascularization, so it's a better chance of healing. If the pain is more located towards the bone, with less vascularization, like I said, in every insertional tendinopathy, it's more difficult to treat. So when I have a patient and whenever the pain is more distally from the bone, I'm more happy. That's just clinical experience. I hope it answers. Anyone else? Either everything is clear or nothing is clear. So. Okay, it's been 2 long days. We came to the end. Thank you very much for joining us here today, and hope to see you before the next Handball World Cup in Doha.